In this video, we will be discussing few key electrical abnormalities of heart that has been represented with ECGs. These disorders that we will be discussing in this section has been very many times repeatedly asked in various PG entrance boards across India. So, please pay close attention. These are all very significant ECG changes that we have to pick very easily from our ECG based questions, doctors. So, the first disorder we will be seeing is premature ventricular complexes, right. So, before we get into the topic as such, I want you to comprehend the names, doctors. What is premature ventricular complexes? So, as the name itself tells you, so it is a ventricular conduction, it is a ventricular contraction, but it is not a normal sequence, rather it is a premature event, okay. So, the normal sequences, you have SA node activating AV node activating ventricles. This is normal sequence. In premature ventricular complex, you have a non-AV nodal excitation happening to ventricles. Okay, doctors, a non-AV nodal excitation happening to ventricles. Ventricles are getting triggered by a source not from AV node but from some other extra sources. Always remember, a normal conduction is faster. Nothing is as fast as SA nodal excitation, right? Unless otherwise the abnormality is extremely severe, SA nodal excitation will be the fastest of all the conduction, doctors. So, when there is a non-AV nodal kind of excitation, and that reaches the ventricle, the timing of depolarization of ventricles will be comparatively slower than SA nodal activation, okay. It will be very slow than the conventional SA nodal, AV nodal ventricular tract. This slow conduction, okay, the slow excitation of ventricular activity, makes QRS complex to appear very broad, okay. The slow excitation makes QRS complex to appear very broad, doctors. So, point number 1, since it is a non-AV nodal, non-SA nodal excitation reaching the ventricle, obviously there is not going to be a P wave, isn't it? P wave represents atrial depolarization. It means the activity starts from SA node. Since it is a non-SA nodal activity, there is not going to be a P wave. There is no P wave preceding a premature ventricular complex. There is no P wave preceding a premature ventricular complex. Now, in this ECG, if you could able to see, doctors, we have two consecutive normal rhythm, okay. We have a two consecutive normal rhythm P QRS T followed by the next rhythm P QRS and T. So, we have P wave, we have QRS morphology, we have and T wave. Two consecutive normal rhythm is followed by one abnormal premature complex, okay. It is followed by one abnormal premature complex, right. So, there is no P wave preceding a premature ventricular complex, and the QRS will be very broad, and this broad QRS, doctors, is a timing, right. It extends more than 200 millisecond. The QRS morphology extends more than 200 millisecond in its timing. Now, since it is a premature excitation and not coming from sinoatrial node, and since ventricle takes a longer duration of excitation, its repolarization also takes up a longer duration of timing. So, since a sudden interruption of event takes place, say for example, there is ventricular excitation happening from SA node, ventricle excites, ventricle goes for contraction. Before ventricle relaxes properly, there is going to be another wave not from SA node but from another ectopic condition. So, this additional wave is going to activate the ventricle. So, without adequate relaxation, the ventricle goes for next excitation, next contraction. So, the second contraction, the moment if it is over, ventricle takes a extra length of relaxation so that it restores all its nutrients and essential ingredients needed for the second excitation and contraction, doctors. So, with every single premature ventricular complexes is over, ventricle takes a extra duration of pause, and that we call as compensatory pause. Okay, look here, in normal QRS complexes, the time with which one PQRST and second PQRST occurs, right, two consecutive excitation occurs in a very small spaced timing, whereas if there is one premature ventricular complex, it takes up a lengthier compensatory pause. Okay, a premature ventricular complex takes up a lengthier compensatory pause, doctors. It takes up a lengthier compensatory pause. This zone is called as compensatory pause. So, we have one such compensatory pause here, right. So, every single QRS complex is followed by, every single premature QRS complex is followed by a lengthier compensatory pause. Point number 3 and point number 4, doc. Now, if you could observe, there is one unwritten law to diagnose or to be present in premature ventricular complexes, that is, the morphology of QRS complex will always be opposite to the morphology of ST segment and T wave. If QRS is upright, STT will be downright and vice versa. In this case, you have a upright QRS complex. See, you have a upright QRS complex which is followed by a downright ST segment as well as T wave. So, ST segment and T wave, ST segment and T wave are opposite in morphology, than QRS complex. ST segment and T wave has got opposite morphologies than QRS complex. These 4 points are the classical feature of a premature ventricular complexes. Remember, there is no P wave preceding a PVC QRS. Every single QRS will be prolonged more than 200 millisecond. Every single PVC QRS is followed by a compensatory pause. There is always ST segment and T wave in opposite morphology to QRS complex. Now, yet another point I would like to bring to your attention, doctors. Now, this is a clue to differentiate between the ectopics occurring from ventricle or outside ventricle, that means atrium and other structures. Okay. So, guys, if it is a ventricular pathology, more or less there will be QRS prolongation or there will be broad QRS. If it is a ventricular pathology, there will be QRS prolongation or broad QRS. If it is supraventricular, if the pathology is primarily supraventricular or extraventricular, anywhere outside the ventricle is absolutely fine, it is just responding to the excitation coming from structures beyond ventricles, right. It can be bundle of us, it can be AV node, it can be atrial myocytes, it can be SA node, anywhere it is. If the ectopics, if the triggered activity, if the enhanced automaticity does not involve ventricular myocytes as such, when the ventricle itself is anatomically perfect and intact, most of the time QRS complex will be very normal or sometimes even narrow. So, supraventricular or extraventricular pathologies will have either normal or sometimes narrow QRS So, remember, doctors, this is a kind of clue. When the ventricles are involved in pathology, this QRS will be broad. When the ventricles are anatomically fine, okay, when the ventricles are anatomically very fine, if it is purely either supra or extraventricular, it will have a narrow QRS complex, right, doctors. QRS will be very narrow. So, these are all the features that we need to bear it up in mind. Here in premature ventricular complexes, since we are looking at a broad QRS complex, more or less we can able to conclude that the pathology or the triggering activity is primarily involving ventricles, right, doctors. So, this is premature ventricular complexes. With this we finished premature ventricular complexes, we will extend our discussion to re-entry pathways. Now this is one crucial point you got to remember, doctors, because this re-entry is the fundamental mechanism with which multiple tachyarrhythmias are occurring in the heart, right. If you could get quite deep into the re-entry mechanism, it will be very surprising, right, because whenever and wherever we describe a heart block, a conduction block, we always think in terms of bradycardia, isn't it? But not so in re-entry pathway. Re-entry is also a pathophysiology of conduction block, right. It is basically a conduction abnormality, but instead of producing bradycardia, re-entry will leads to tachycardia. So what happens is, consider we have one Purkinje fiber. We have one Purkinje fiber, and this Purkinje fiber divides into two branches. Purkinje fiber divides into two branches, doctors. We have branch 1 and we have branch 2, two branches, and let us connect these two branches. So we have an additional third branch, okay, we have a third branch here. So this is branch 3. So this is how a Purkinje fiber is being arranged, okay. Let us take up this one example first, and we need the same picture for the next time also. So I am just getting the very same picture on the opposite side. Okay guys, so let us see the normal conduction first. Normal conduction first. What happens is, when impulse pass through main Purkinje fiber, it tries to branch out into both the branches, branch 1 and branch 3. So there will be conduction in both the branches. So every branch will take up the current, and if you record current travel in each branch, you will have myocyte action potential in each branch down. But look here, branch 3 could get current from both branch 1 as well as branch 2. So what happens is, you have current coming from branch 1, you have current coming from branch 2, both these currents meet at the middle, they try to cancel each other. So in branch 3 you will have cancellation of current, okay, you will have cancellation of current in branch 3. You will have cancellation of current in branch 3. This is how normal conduction takes place. This is how normal conduction takes place, doctors. Okay, good. So now what happens in re-entry mechanism? What happens in re-entry? The first and foremost pathophysiology, as I just described at the beginning of re-entry system, is the conduction block. Let us consider there is a conduction block in this case, doctor. Let us consider there is a conduction block. So because there is a conduction block, we cannot have the impulse traveling in the main Purkinje branch could not able to cross across, okay. The main impulse cannot able to cross across the conduction block, blocked conduction. So on the other side we have normal conduction in branch 1, we have a normal myocyte action potential that can be recorded in Purkinje fibers and its supplying areas. Now here, since in branch 3 there is no current coming from branch 2, now branch 3 acts as a wide open highway to allow current from branch 1 to cross across. So this takes the current to travel in branch 3 and again entering into branch 2, doctors. For some unknown reason, we have a specific delay or specific block or defect in orthodromic conduction alone, whereas antidromic conduction is happening perfectly alright. So what happens is, since orthodromic is inhibited and antidromic conduction is happening without any hassle, the current that is coming from branch 1 and branch 3 turns into branch 2, it crosses the conduction block site. It crosses the conduction block site, it reaches the main trunk, So this is the first and foremost mechanism for re-entry pathway. As this re-entry current reaches branch 1, here we have the first pathology we just discussed, that is conduction block. In one branch, and if you consider the conduction block, this is very specific, doctors, isn't it? Number 1, the conduction block is only for orthodromic, that is antigrade conduction, okay, only for orthodromic conduction, whereas there will be absolutely normal antidromic There will be very normal antidromic conduction, right. So, the first pathology is conduction block, doctors. Now, the same picture let us apply here. What happens is, by this time, okay, by this time if branch 1, if branch 1 happens to be in resting membrane potential, which means the electrical activity in branch 1 is over. By the time the current that is coming via branch 3 to enter into branch 2 to reach the parent branch, okay, by this time if the branch 1 fibers and cells finishes their action potential and goes to resting membrane potential, they are susceptible for re-excitation. So, in this phase only in this phase, as branch 1 is going for resting membrane potential, the current that has just travelled, across the block, okay, the current that has just travelled across the block will now try to enter into branch 1 again, branch 1. This starts a loop, of current happening between branch 1 and branch 2. This happens in a loop. So, this loop continues n number of times, leading to formation of tachycardia, doctors. So, for tachycardia to occur, the first and foremost pathophysiology by re-entry is conduction block in one branch, and the second pathophysiology is one other branch. It should be in either effective refractory period, or it should have reached resting membrane potential, which means the other branch should be susceptible for excitation. Doctors. So, these kinds of pathophysiology are the ultimate fundamental mechanism that contributes to tachycardia, and foremost important tachycardias because of such a kind of re-entry is AV nodal re-entrant tachycardia, as well as Wolff-Parkinson-White syndrome. These are all few examples of re-entrant tachycardia that has been very many times repeatedly asked in PG entrance exam. So, I want you to be very familiar with the mechanism of re-entry, doctors. Always remember, two things are very crucial. Number one, there should be a block in one pathway. Number two, the other pathway should be susceptible enough to be responsive for excitation. So, the second pathway should either be in effective refractory period or it should be in resting membrane potential. So, the timing is very crucial here. If the timing is right, the re-entry can happen n number of times, leading to continuous arrhythmia generation, doctors. Okay, so that is re-entry. Coming to supraventricular tachycardia, the third condition. Remember, every word is important. Supraventricular tachycardia, which means there is increased heart rate. Right? Now, this increased heart rate is driven. By abnormalities above ventricles. Right, doctor? So, it is not going to be a ventricular ectopics. The problem is solved, right? It is not a ventricular pathology, it is a supraventricular pathology. What is the structure that is lying ahead of ventricle and keep triggering the ventricles? Nothing but AV node, isn't it? So, supraventricular tachycardia are primarily a pathology of AV node or instead sinoatrial node, right, doctors? So, supraventricular tachycardia can be of four types. Supraventricular tachycardias are of four types, okay. Number one, AV nodal, most important, AV nodal re-entrant. Tachycardia. Number 2, atrioventricular reciprocating tachycardia. Number 3, sinoatrial node. Just like AV nodal re-entry, we have sinoatrial reentrant. We have sinoatrial reentrant tachycardia, that is third variety. Number fourth variety, interatrial reentrant tachycardia, doctors. We have four varieties of supraventricular tachycardias. Now, the mechanisms, if you consider the mechanisms, doctors, three events favors formation of supraventricular tachycardia. Number one, we just saw that, isn't it? Re-entry. Number two, enhanced excitability, enhanced automaticity of AV node, doctors. Number three, triggered activities. These three events contributes to supraventricular tachycardia. Now, if you could observe the ECG rhythm, if you could remember what we discussed in the previous section, doctors, premature ventricular complexes, I was telling you about one point. If the pathology is not arising from the ventricles, the QRS morphology will be more or less narrowed. If the pathology is, primarily a ventricular pathology, you will have broad QRS. If it is primarily a non-ventricular pathology, you will have a narrow QRS. Okay. So, the manifestations of supraventricular tachycardia here, if you could see, the first and foremost pattern is narrow QRS complex. Okay, doctors. Point number one is narrow QRS complex. It is tachycardia, right, and the rate happens to be about, right, 180 to even 280 beats per minute. It is tachycardia. Okay. Now, yet another feature, if you could observe, is there is absence of P waves. So, what does this tells you? Does this mean sinoatrial node is not getting involved? No way. Please look here. You have very good sinoatrial activity. Instead of well prominent sinoatrial activity, still we cannot able to see P wave, doctors. Why? The reason is, of course there is P wave, but here P wave is merged with QRS complex. P wave is merged with QRS complex. It can be seen either before QRS arising or after QRS arising. So, close to Q wave or close to S wave, anywhere P wave will get merged with QRS complex, because the rate of ventricular activity is so much great that well before P wave comes and gets recorded in a ECG paper, you will have a QRS incoming. So, the P wave will be merged with QRS complex. So, this is the reason why you cannot able to see P wave. Please remember, just because P wave is absent in this ECG, it does not mean doctor, sinoatrial node is not getting activated. There is a well active sinoatrial node, but the pathology is there are more ventricular activation than sinoatrial activation. This leads to merging of P wave with QRS complex. And in supraventricular tachycardia, I want you to remember this one point. There is always narrow QRS complex. Doctors. Right? Good. So, this is supraventricular tachycardia. Now, coming to the fourth condition, that is ventricular tachycardias, right. Just have a look at the ECG first. Now, the condition clearly tells you this is a ventricular pathology, right. As we just discussed in supraventricular tachycardias or premature ventricular complexes, this is primarily a ventricular pathology, doctors. This is primarily a ventricular pathology. It's a ventricular tachycardia, which means the ectopics or triggered activities are situated in ventricle itself. Okay. So, the first and foremost point, look at the QRS. It is going to be a very prolonged QRS complex. Definitely, it is not going to get restricted to 120 millisecond. Okay. So, ventricular tachycardias, the rate can be very normal, just like SVTs. Rate can be very similar to SVTs. It can be about 180 to 280 impulses per minute. We cannot differentiate with rate of cardiac activity to say whether this is a SVT or VT. The only differentiating point is there is going to be a broad QRS. There is going to be a broad QRS complex. So, remember doctors, very easy. If there is a tachycardia and if it is a broad QRS complex tachycardia, your diagnosis is very simple, it is ventricular in origin. This is ventricular tachycardia. If your ECG paper shows tachycardia and all the QRSs are very narrowed with absent P wave, this is a supraventricular tachycardia. As simple as that. Absent P wave, narrow QRS complex, supraventricular tachycardia. With the broad QRS complex, presence or absence of P wave is absolutely immaterial. When the QRS complex is very broad and you have a continuous tachycardia appearance in ECG, the diagnosis is very straightforward. It is ventricular tachycardia, doctors. Straightforward. Okay. So, ventricular tachycardias are seen, the characteristic feature is broad QRS complex. Enlarged QRS is a characteristic feature of ventricular tachycardias. Moving on to Wolff-Parkinson-White syndrome. See guys, it is very simple, we just discussed that in re-entry ECGs, right. Wolff-Parkinson-White syndrome is due to an abnormal presence of an accessory pathways. Okay doctors, normally speaking we have atrium and we have ventricles. Atrium and ventricles are not coupled, right, they are not connected through mechanical junctions, right. You have a intervening connective tissues, you have intervening non-excitable fibrous connective tissue separating atrium from ventricles, right. The only way with which impulses from atrium can be transmitted to ventricles is through AV node. AV node is the only way with which current from atrium can be transported to ventricles. But in Wolff-Parkinson-White syndrome, apart from the original AV nodal conduction, you also have an accessory pathway that takes the current from atrium to ventricle. Now this pathway is called as, okay guys, this accessory pathway is called as bundle of Kent. This accessory pathway is called as bundle of Kent, and this is going to carry the conduction from atrium into ventricle. This is going to carry the conduction from atrium into ventricle. Now, when ventricles are going to get excited well in advance, right? Now remember, bundle of Kent is always faster than AV nodal conduction. Since bundle of Kent conducts current in a much faster velocity, there is going to be a prominent pre-excitation of ventricles, which means ventricles do not have to wait for AV nodal conduction to happen. Well before bundle of His and Purkinje fibers takes current from AV node, bundle of Kent straight away gets the current to ventricles, right. Just because bundle of Kent takes the current to ventricle gets excited much early. So this leads to a condition called as pre-excitation of ventricles. As ventricles are going to get pre-excited, doctors, what happens is there is going to be shortened PR interval. There is going to be shortened PR interval, classical feature, there is going to be PR narrowing. And the second classical feature is, since it is a pre-excitation, right, the normal excitation will have normal QRS. Since it is a pre-excitation, you have a slopy QRS complex. Slopy QRS like this. QRS won't start somewhat like this, okay. You have QRS instead to become PR interval that continues to form QRS. Now this slope, remember doctors, this slope of QRS is what is called as early excitation. The slope of QRS is called as early excitation, also called as delta wave, So shortened PR interval with presence of delta wave is a characteristic feature of Wolff-Parkinson-White syndrome, doctors. If you could observe in ECG, see here we have normal P wave, we have a normal P wave. There is absolutely no PR interval, very reduced PR interval. And look at the slope, doctors, look at the slope here, look at the slope, look at the slope. So this slope indicates early excitation, this slope indicates early excitation, which is nothing but delta waves, which is nothing but delta waves. This is Wolff-Parkinson-White syndrome, this is Wolff-Parkinson-White syndrome, doctors.